Hello, my name is Vivian Haggerty. I am a third-year medical student at Florida Atlantic University, Charles E. Schmidt College of Medicine. Today I will be presenting ventriculoatrial shunts as an alternate therapy in patients with normal pressure hydrocephalus refractory to ventriculoperitoneal shunts, a case series. Normal pressure hydrocephalus, or NPH, is the pathological enlargement of ventricular size with a normal opening pressure in the absence of a structural blockage of cerebrospinal fluid, or CSF. Classically, NPH presents with the triad of dementia, gait disturbance, and urinary incontinence. NPH is commonly seen in elderly patients, with the highest incidence in patients 80 years or older. Despite the incidence of NPH being lower than other causes of dementia, its potential reversibility prompts the necessity for reliable treatment modalities. The first-line treatment for NPH focuses on CSF diversion to reduce the ventriculomegaly, potentially reversing the pathology. Diversion is attained through shunt insertion from the ventricular system into other cavities of the body, such as the peritoneal cavity, the pleural cavity, or the right atrium. Most commonly, the diversion of CSF is into the peritoneum via a ventriculoperitoneal shunt, VP, or less commonly the right atrium via ventriculoatrial or VA shunt. A significant limitation with VP shunts is their rate of failure, which is especially evident in the setting of increased intra-abdominal pressure, particularly when anti-siphon devices are utilized. In these cases, CSF flow is determined primarily by pressure differential between the intracranial and abdominal cavities. Previously, intra-abdominal pressure, or IAP, was thought to be zero in all patients. However, emerging evidence demonstrates IAP is only close to 0 millimeters of mercury in thin patients with a low BMI, but elevated in overweight or obese patients, with some studies showing a linear relationship between BMI and IAP independent of sex. This is especially concerning given recent estimates show that adults over age 60 have obesity rates exceeding 37.5% in males and 39.4% in females. The increase in IAP can cause a significant reduction in CSF flow into the peritoneal cavity, ultimately resulting in minimal to no clinical improvement of symptomatology following shunt placement. This explains a lack of improvement after VP shunting despite the fact that the patients had prior successful lumbar puncture LP or lumbar drain LD trials. This article aims to retrospectively analyze the successful placement of VA shunts in two patients with NPH and elevated IAP secondary to obesity. We describe the clinical course of these patients and recommend a VA shunt for treatment of NPH in select patients. Case 1. An 82-year-old male began suffering from short-term memory loss, urinary incontinence, and a shuffling gait in 2016. In 2018, an LP was performed in the hospital and the patient was observed for a few days. This led to an improvement of his previously mentioned symptoms. Subsequently, a Medtronic Neurotech Strata ventriculoperitoneal shunt was placed with no improvement in gait or cognition. The patient's symptoms continued to progress, with a deteriorating memory, cognitive impairment, and an unsteady, worsening shuffling gait. The patient was seen in clinic as a follow-up in July of 2020, where a shunt tap produced improvement in gait and cognition within 24 hours. Of note, his BMI was 27 with truncal obesity. 2 weeks later, the patient presented to the emergency department with neurological decline, aphasia, and intermittent confusion. Head CT revealed evidence of worsening hydrocephalus, potentially attributable to enlarging ventricles. The catheter from the previous ventriculoperitoneal shunt was noted to be correctly positioned. Based on concern for a malfunction of the proximal valve of the VP shunt, we performed surgery on the patient to replace the Medtronic Strata valve with a Codman Certas anti-siphon valve. During the procedure, we disconnected the valve proximally, revealing brisk flow. We disconnected the valve distally and used a manometer to check the distal flow. The distal flow was patent, and the manometer stopped at approximately 12 centimeters of water, with the patient supine, consistent with adequate shunt function. The valve was patent. A new Codman anti-siphon valve with a pressure of 5 was placed. We attributed the malfunction to the valve. On post-op day 1, the patient's poor cognition and unsteady gait persisted. We adjusted his shunt pressure from 5 to 4 with minimal change. On post-op day 5, we performed a bedside shunt tap and drained 35 cc's of CSF, providing rapid symptom relief. We felt the shunt was not performing optimally due to high intra-abdominal pressure, and the following day converted his VP shunt to a VA shunt. On post-op day 1, the patient was noted to be more alert. He was discharged to rehab to work with a physical therapist. On 2-week follow-up, the patient reported significant improvement in his symptoms, including improved mentation, longer strides, and less urinary frequency. His speech was noted to be more fluent. At 6-week follow-up, these improvements persisted. At a 6-month follow-up, the patient's conversant demeanor was illustrated from flowing conversations about his medical history to current political appraisals. He continued to demonstrate improved mentation and reported less urinary frequency and improvement in his walking through longer strides and being able to walk for longer periods of time. Case 2. An 87-year-old male experiencing short-term memory loss, shuffling gait, and urinary incontinence was seen by a neurologist, who then referred him to a neurosurgeon based on CT head findings revealing ventriculomegaly. In October 2019, a Codman Certas VP shunt was placed based on an initial diagnosis of normal pressure hydrocephalus. Following the procedure, his shuffling gait and cognition continued to worsen despite lowering the valve settings. A CT brain in December 2019 revealed mild hydrocephalus with a shunt in place. The patient was first seen in our office in February 2020, where we performed a shunt tap, draining 35 cc's of CSF. Of note, his BMI was 28 with truncal obesity. His family reported improvement in his walking and cognition over the next 24 hours, after which his symptoms returned. We felt these findings were consistent with shunt malfunction. Due to this concern, 1 month later we performed surgery on the patient. We exposed the shunt and disconnected the valve both proximately and distally. The valve was patent. We replaced the valve with a Codman Certas anti-siphon valve at level 5. Upon testing the distal shunt, we observed a distal pressure of 25 centimeters. We felt this pressure indicated an excessively elevated intra-abdominal pressure, necessitating an alternate approach. We removed all distal tubing from the abdomen through a transverse anterior cervical incision and placed the tubing into a branch of the external jugular vein and converted the shunt from VP to VA. At 2-week post-op, the patient reported less pressure in his head, leaning less, and improved walking. These findings were corroborated by his wife. We maintained his shunt setting of 5. At 2-month post-op, the patient reported resolution of the pressure in his head. We adjusted his shunt from 5 to 4. At 3-month post-op, the patient continued to report improvement in his walking, urinary frequency, and mentation. CT brain showed stable ventricular size, and his VA shunt reservoir depressed and refilled briskly. We believe the improvement in the patient's symptoms is attributable to the VA shunt. At a 10-month follow-up, the patient continued to experience continued improvement in walking, frequency, and mentation. Furthermore, these improvements are elucidated through his overall demeanor and significant improvement in quality of life. Normal pressure hydrocephalus is a prevalent and possibly underdiagnosed neuropsychiatric disorder, particularly in the elderly population, with the prevalence estimated at 22 per 100,000. Although the precise nature of the pathophysiology remains unclear, its symptomatology is characterized by the triad of dementia, gait disturbance, and urinary incontinence in the setting of ventriculomegaly. Gait abnormalities are the most common findings, and the triad itself is only seen in the minority of patients. NPH may coexist with other pathologies, including Alzheimer's disease, spinal stenosis, and Parkinson's disease. Ventriculoperitoneal shunting is largely considered the definitive therapy for NPH. We described two cases of successful VA shunt therapy for normal pressure hydrocephalus in which treatment with VP shunts was unsuccessful from the outset, despite improvement by LP or LD preoperatively. In both instances, patients continued to deteriorate clinically following shunt placement, prompting unrevealing surgical evaluations of the shunts. Findings included unremarkable CT findings with no change compared to preoperative appearance, good refill at reservoir, no evidence of infection, and no improvement with lowering valve settings to the lowest available. The diversion of fluid performed by shunt therapy for NPH is dependent on a distal pressure lower than the patient's intraventricular pressure. Although intra-abdominal pressure is often assumed to be close to 0 millimeters of mercury, a linear relationship exists between BMI and IAP. Overweight and trunkily obese patients may have elevated IAP of great clinical significance for VP shunt placement, and this variable merits consideration when neurosurgeons select which distal cavity is most appropriate for their NPH patients. This is especially important as most neurosurgeons utilize anti-siphon valves that limit flow in the upright position. Current projections suggest that by 2030, nearly half of U.S. adults will be obese, with nearly one-fourth classified as severely obese. Severe obesity is projected to become the most common BMI category for women, Black non-Hispanic adults, and low-income adults. VP shunt placement remains the most commonly performed procedure for NPH, and VA shunt use has decreased worldwide, possibly a consequence of the perceived technical challenges and potentially serious associated complications, including cardiac arrhythmias, pulmonary hypertension, thrombus formation, and damage to myocardial tissue. In addition, shunt infection in a VA placement may cause bacteremia and sepsis. VP shunts have been utilized especially in children, where growth may allow the shunt to remain in the intended cavity without pulling out. However, ultrasonographic, fluoroscopic, and electrocardiographic guided techniques are available and effective in preventing these complications and ensuring correct placement of the distal atrial catheter near the cavo-atrial junction. Retrospective studies examining the safety and efficacy of VP and VA shunts for NPH found no significant differences in perioperative and postoperative complication rates between the two groups. None of the VA group patients suffered cardiopulmonary complications, and one study reported patients in the VA group were significantly less likely than patients in the VP group to require shunt replacements or revisions. Although our results examine only cases of successful VA shunt therapy for NPH in patients with IAP secondary to obesity, IAP is seen in other pathologic conditions such as cirrhosis, hepatorenal syndrome, nephrotic syndrome, and decompensated heart failure. Our study is limited by sample size and cause of IAP examined. The important point of our study is to question the shunt in these cases of NPH where LP and LD had excellent results that were not sustained after VP shunt placement. Of interest, both patients had their original shunts placed elsewhere and were told their shunts were functioning adequately by other neurosurgeons. Further research is needed to assess the appropriate target for distal shunt placement in non-obese patient populations, and more research is needed to confirm or refute our findings of superior clinical outcomes with VA shunt placement in obese patients with NPH compared to VP shunts. Thank you for your attention.